Precedex, dexmedetomidine hydrochloride injection, is an innovative IV agent that offers effective sedation for both intubated and non-intubated patients. Precedex is indicated for sedation of initially intubated and mechanically ventilated patients during treatment in an intensive care setting not to exceed 24 hours, and for sedation of non-intubated patients prior to and/or during surgical and other procedures. Precedex should be administered by continuous infusion. Precedex is different than other commonly used IV sedative agents. Precedex is an alpha-2 adrenoceptor agonist that exerts its effects via the alpha-2 adrenoceptor. This is a distinctly different mechanism of action than that of propofol or a benzodiazepine. Unlike many other sedatives used in the OR and ICU, Precedex is not a controlled substance. This video explains what Precedex is, how it is different, and how to administer it to intubated and non-intubated patients needing safe and effective sedation. Precedex has been found to work on the alpha-2 adrenoceptors that are located throughout the body, including the central nervous system, effector organs such as vascular smooth muscle, and especially in tissues innervated by the sympathetic nervous system. Precedex has been shown to produce sedation, inhibit sympathetic activity, decrease blood pressure and heart rate, and reduce the need for add-on morphine. Precedex has been shown to maintain respiratory stability. The respiratory effects of Precedex after extubation in the intensive care unit were retrospectively examined in 33 post-surgical patients involved in a randomized placebo-controlled trial. There were no significant differences in respiratory rates, oxygen saturation, arterial pH, and arterial partial carbon dioxide tension between the Precedex and placebo-treated groups. As seen here, patients randomized to receive either Precedex or placebo maintained consistent oxygen saturation rates before, during, and after extubation. Precedex can be continuously used in patients prior to, during, and after extubation.
First and foremost, Versed or midazolam, whether it's pushed or whether it is in a drip form, has to be discontinued, allow the respiratory rate to rise, and then extubate the patient. And the same thing occurs with propofol. You need to discontinue it about 10 minutes before extubation, allow them to, their respirations to come up to their baseline, and then extubate them. Dexmedetomidine may give you the ability not to have to do that. You're able to extubate this patient while leaving them covered from a sedative perspective versus the other agents which you have to stop, and during probably one of the most anxiety-provoking experiences.
Oftentimes in the PACU, patients come out intubated, either with an LMA or with an endotracheal tube, and it's my responsibility as a PACU nurse to extubate them. Patients who have had Precedex, I can look at them, I can talk to them, I can help them understand, yes, you have a breathing tube in, don't worry, you're safe, it's okay, I'm here with you, this is what I need you to do. And for the most part, they're very cooperative because it takes away the fear element. They don't feel afraid or uncertain. They can understand and they know what's happening. And the good thing is they pretty much forget afterwards. The same thing with open heart patients. I can place a patient on a wean and bring them up slowly. I'm talking to them. I need you to breathe. I need you to cough. I need you to hug your pillow against your chest. And they're cooperative, and which makes for a faster extubation and less pain on their part.
In Phase 3 clinical trials of ICU patients, Precedex was shown to reduce the need for morphine. Significantly fewer patients sedated with Precedex required add-on morphine for analgesia than control patients. In those patients who needed add-on morphine for pain control, the mean total dose was significantly less in patients sedated with Precedex versus control. This graph shows that significantly more patients treated with Precedex attained significant pain relief without additional morphine in Phase 3 clinical trials of ICU patients. In 2 trials, 44% and 41% of Precedex patients did not require add-on morphine, while this was true for only 19% and 15% of the placebo groups.
I think using Precedex, in my opinion, decreases the need for narcotics. It's a smoother wake-up. They wake up, they're pleasant, they're not agitated, they're easier to orient, to tell the patient what's going on, where they're at, what's going to happen to them. They still feel pain, but you don't have to knock them out with narcotics to make them comfortable. It's such an adjunct to nursing therapy, to narcotic therapy.
Precedex also significantly reduced the average dosages of morphine needed to obtain adequate analgesia during the first 6.5 hours of study drug infusion. The data reflect the results of a prospective secondary analysis of 2 Phase 3 multi-center double-blind placebo-controlled studies designed to evaluate the efficacy and safety of Precedex in patients who required mechanical ventilation and sedation in an intensive care setting. Patients sedated with Precedex needed, on average, 4.5 milligrams of morphine, compared with placebo-controlled patients who needed significantly more morphine, 8.5 milligrams, in order to maintain adequate analgesia. Precedex also has fentanyl-sparing properties. This was shown in a study of 326 non-intubated patients requiring max sedation for elective surgeries or other procedures in an operating or procedural room setting. To maintain adequate analgesia and patient comfort, IV boluses of fentanyl 25 micrograms could be administered. Patients received fentanyl for pain if their pain score was 3 or greater during the procedure, or 4 or greater in the PACU. Pain was measured on a scale of 0 to 10, where 0 equals no pain and 10 equals the worst pain ever experienced. Patients were randomized to receive a Precedex loading dose of 0.5 micrograms or 1 microgram over 10 minutes, followed by a maintenance dose of 0.6 micrograms per kilogram per hour, which could be titrated within a range of 0.2 to 1 microgram per kilogram per hour. Rescue midazolam could also be given. The placebo group received a matching saline infusion plus or minus rescue midazolam. All patients were titrated to the same level of sedation. As you can see, only 60% of patients in the Precedex 0.5 microgram group and 43% of patients in the Precedex 1 microgram group required add-on fentanyl, versus 89% in the control arm. The dose of fentanyl required was also significantly less in the Precedex groups, 85 micrograms and 86 micrograms respectively, versus 151 micrograms in the control arm. The sedative profile of Precedex can differ from that of other IV sedative agents you may be more accustomed to using. Patients in the Phase 3 clinical trials reached clinically indicated levels of sedation and were adequately sedated, Ramsay sedation scores of 3 or more. However, when stimulated, some patients were reported as arousable and alert. Many patients sedated with Precedex may seem more arousable or alert when stimulated than with other sedatives you may be more accustomed to using. This is important for clinicians and caregivers to understand, because the ability to be aroused should not be considered as evidence of lack of efficacy in the absence of other clinical signs and symptoms. When a patient is sedated with Precedex, the decision to administer additional analgesics or sedatives should not be based solely on the ability to arouse the patient. Adding unnecessary concomitant sedative agents and/or opioid analgesics may produce unwanted side effects. Before determining the need to administer additional analgesics or sedatives, question the patient to assess their true comfort level. This can be done by talking to the patient or by using a sedation or pain scale for an objective pain or comfort assessment if the patient is intubated.
When I first used dexmedetomidine, it was a different type of sedation and not something that I was used to. We were used to titrating these sedative agents that sort of have a linear response. The more you give, the less responsive the patient is, and you can titrate it to some level of responsiveness usually, but oftentimes patients don't respond. And if they can respond, it's often that they're in a lighter plane of sedation than you want. We found something very different with dexmedetomidine when we first used it. These patients were patients who were well sedated by any criteria you would choose to use. They were calm, but when you spoke with them, they'd open their eyes instantaneously, like they were rousing from sleep almost, and follow commands, interact with you appropriately, and then when you stepped out of the room and left them alone, they'd fall back asleep again fairly quickly. So this was very different for us, and it took some getting used to. I think the nurses particularly were more used to having patients who were sedated and not responding, and they were concerned that these patients who were responding were not adequately sedated, where in fact they were well sedated.
Hi. You have any pain? You have any issues at all? Is your chest okay? You want to write me a note? Can you write me a note? Oh, the breathing machine's fighting you? Okay. Alright, we'll take care of that. Go back to sleep a second, and we'll be done in a little bit. Okay. One more? Otherwise, everything going great. Yeah, we feel the same way. Okay, can you just rest a little bit, close your eyes and take a rest, okay? I'll get you off this machine, alright? Okay, just relax, close your eyes, take a nap.
The sedative profile of Precedex may seem different than that of many sedatives. This is particularly important in ICU patients, where balancing patient comfort with the need to conduct accurate daily assessments can sometimes be difficult in sedated intubated patients that can't speak.
We find that using Precedex allows us to keep them comfortable, tolerating an endotracheal tube and ventilation, and yet we're able to assess them neurologically very, very well. We use propofol quite often for the anesthetic infusion for neurospine cases. However, in order to get a patient to a level of sedation where they're fully awake enough to actually give us a neuro exam and yet be comfortably tolerating the tube, we usually find titration with Precedex to be far more efficient in that way. Propofol, we have certain limitations on what nurses can push on the floor, how much they can give. It's still a very useful tool in our operating room, but in these cases specifically, when we want to get an accurate neuro exam and yet make sure the patient is comfortable, we usually find Precedex is pretty flexible that way. When we first started using Precedex, there was some trepidation about using it. Obviously, we have the benzodiazepines, we had narcotics, we had propofol, and thought, why do we need another agent? And of course, titrating all those agents, you could probably come to a very similar state of analgesia and relaxation for patients, although it's multiple titrations with multiple medications and people don't react the same. This allowed us a little bit more flexibility with one medication. And while initial anxiety about new medication is always expected, after we've started using it more routinely, a lot of my nurses in the ICU would kill me if we took it away. The reason the nurses have latched on to Precedex is that it allows them to do the nursing assessment and be able to give real input into how they feel the patient's doing. Obviously, the new thing is pain, and that's always considered the fifth vital sign. You really can't assess pain in someone who's totally anesthetized. You can just assume they're not feeling it because they are not doing anything. So with Precedex, we're able to get some idea of, are they in pain or are they not in pain? If they are in pain, then they simply get additional analgesia. If they're not, there's no reason to give them anything else. Also, the patient can cooperate. They can tell you if they're uncomfortable. They can tell you if they have difficulty breathing. They can tell you if there's something wrong. In a patient who's under a combination of medications, which generally equals general anesthetic, they're not able to cooperate with you at all, and you have really no idea how they're doing unless you can second guess them.
I've had the opportunity to use Precedex in a variety of settings. The first time I had an experience with it was recovering an open heart patient. We did not only bypasses and valves, but we also did heart transplants. And back when I started nursing, the patients were intubated for days and days and days, and they figured out that it wasn't such a good thing. So to extubate them quicker, a lot of the surgeons and anesthesiologists started to go with the Precedex. And we were able to decrease our intubation times to between 3 and 6 hours post-op, and fast-track these patients with Precedex, which cut the amount of days in the hospital, cut the rate of infection, and generally made for a happier patient and a happier nurse.
The sedative profile of Precedex can differ from that of other IV sedative agents you may be more accustomed to using. Patients in the Phase 3 clinical trials reached clinically indicated levels of sedation and were adequately sedated, Ramsay sedation scores of 3 or more. However, when stimulated, some patients were reported as arousable and alert. Many patients sedated with Precedex may seem more arousable or alert when stimulated than with other sedatives you may be more accustomed to using. This is important for clinicians and caregivers to understand, because the ability to be aroused should not be considered as evidence of lack of efficacy in the absence of other clinical signs and symptoms. When a patient is sedated with Precedex, the decision to administer additional analgesics or sedatives should not be based solely on the ability to arouse the patient. Adding unnecessary concomitant sedative agents and/or opioid analgesics may produce unwanted side effects. Before determining the need to administer additional analgesics or sedatives, question the patient to assess their true comfort level. This can be done by talking to the patient or by using a sedation or pain scale for an objective pain or comfort assessment if the patient is intubated.
Cooperative sedation is good in the OR, probably more useful in the ICUs perhaps. But I think it's good in the OR. It lets us communicate with the patients, find out how they're doing, if they're having any problems. The patients, even though we wake them up and speak to them, don't seem to have much recollection of those events and fall back to sleep quite quickly. It's also useful, for instance, in patients who go apneic. When with many of the other drugs, I can't simply give them light stimulation to wake them up and speak with them, but with the Precedex I seem to be able to do that with a much greater frequency.
Hi. You have any pain? You have any issues at all? Is your chest okay? You want to write me a note? Can you write me a note? Oh, the breathing machine's fighting you? Okay. All right, we'll take care of that. Go back to sleep a second, and we'll be done in a little bit. Okay. One more? Otherwise, everything going great. Yeah, we feel the same way. Okay, can you just rest a little bit, close your eyes, and take a rest, okay? I'll get you off this machine, all right? Okay, just relax, close your eyes, take a nap.
We find that using Precedex allows us to keep them comfortable, tolerating an endotracheal tube and ventilation, and yet we're able to assess them neurologically very, very well. We use propofol quite often for the anesthetic infusion for neurospine cases. However, in order to get a patient to a level of sedation where they're fully awake enough to actually give us a neuro exam and yet be comfortably tolerating the tube, we usually find titration with Precedex to be far more efficient in that way. Propofol, we have certain limitations on what nurses can push on the floor, how much they can give. It's still a very useful tool in our operating room, but in these cases specifically, when we want to get an accurate neuro exam and yet make sure the patient is comfortable, we usually find Precedex is pretty flexible that way.
When I was in anesthesia training in the early 90s, we were taught that there were 5 components to anesthesia. There was unconsciousness, amnesia, analgesia, muscle relaxation, nerve conduction blockade. And that's what we were taught. The textbook said those 5 components, any one or any combination of them, comprised an anesthetic. Today there's a 6th component, and the 6th component is sympatholysis, the ability to interact with the patient and to blunt sympathetic responses to painful stimuli. Now in the past, We did that via nerve conduction blockade, specifically via major conduction anesthesia. We would perform either a spinal anesthetic or an epidural anesthetic, but that was really the major way we got sympathetic blockade. There was a way to do it also with a sympathetic block, but that wasn't very common. But today we have the ability to really blunt sympathetic responses to surgical stimuli using an intravenous drug. This is a really big deal. This is an incredible advancement, and I think it's an incredible tool for the anesthesiologist to have at his or at her disposal. It allows us to really tailor an anesthetic, to really help get the patient through the operation with minimal sympathetic response to surgical stimuli, to cut way back on the other drugs that we commonly used in the past, high doses of inhaled agent, high doses of narcotic, high doses of other drugs, and we're able to have, in my opinion, improved outcomes with lower doses of those drugs that I just mentioned. The way my practice has evolved now is the bulk of the cases I do are bigger, bloodier, or technically more difficult operations. Specifically, a lot of bariatric surgery, gastric bypasses, lap bands, a lot of spine surgery, neck surgery, lumbar fusions, scoliosis, thoracic fusions. Difficult operations and difficult anesthetic challenges. Airway issues in these spine patients with cervical problems, either a very unstable neck because of a fracture or a very tight cervical stenosis, a very limited range of motion of their neck, or history of previous fusions. Difficult airway issues. Same with the bariatric patients. Difficult pulmonary physiology, a lot of them with shunting issues, hypoxemia, sleep apnea, and bad airway anatomy. I've used Precedex in hundreds and hundreds of these patients. I love it. It just gives me so much of an advantage over my colleagues who don't use the drug. I'm able to intubate the patients, sedate the patients easily if I want to, without depressing the respiratory drive. In the past, it required a little bit of Versed, midazolam, a little bit of fentanyl, a little bit of propofol, maybe some topical lidocaine, and to do an awake fiber optic intubation in someone with an unstable cervical spine was a difficult undertaking. Today it's simple. I put nasocanial oxygen on them, I give them Precedex, and I find a very cooperative patient. I can anesthetize their airway and intubate them very easily. The more difficult, the more complex, the more obese, the more tenuous the patient, the more likely I am to use this drug. I think it adds so much to the anesthesia care, to my anesthesia plan, and it really allows me to limit the polypharmacy that we all have come to accept as a standard part of our practice.
I've had the opportunity to use Precedex in a variety of settings. The first time I had an experience with it was recovering an open heart patient. We did not only bypasses and valves, but we also did heart transplants. And back when I started nursing, the patients were intubated for days and days and days, and they figured out that it wasn't such a good thing. So to extubate them quicker, a lot of the surgeons and anesthesiologists started to go with the Precedex. And we were able to decrease our intubation times to between 3 and 6 hours post-op, and fast-track these patients with Precedex, which cut the amount of days in the hospital, cut the rate of infection, and generally made for a happier patient and a happier nurse.
Precedex should be administered only by persons skilled in the management of patients in the intensive care setting. Prior to administration, Precedex must be diluted. To prepare the infusion, withdraw the entire 2 milliliter contents of the vial and add to 48 milliliters of sodium chloride injection to total 50 milliliters. Shake gently to mix well.
The standard dilution that we use is 4 micrograms per mil, and we achieve that with a single vial, which is 200 micrograms placed into a 50 cc bag for short cases, or 2 vials, 400 micrograms placed into 100 cc's, giving us a dilution of 4 micrograms per mil. Little word of caution, it's very easy to make an error with the decimal place, to either not record the 400 mic added to the bag as 0.4 milligrams, perhaps 0.04 milligrams, which will give you a dilution error, or the other way at 40 micrograms. So often what I like to do is, even though I've done this for many years and many times, I still like to recheck myself with a calculator very often. The other thing is, it's infused in micrograms per kilo per hour, as opposed to several other drugs which are infused at mics per kilo per minute.
Precedex has been shown to be compatible when administered with 0.9% sodium chloride in water, 5% dextrose in water, lactated Ringer solution, as well as a number of other intravenous fluids and medications. Please see full prescribing information for a complete list. Precedex is incompatible when administered with amphotericin B and diazepam. Precedex is infused using a controlled infusion device. Dosing is individualized and titrated to the desired level of effect depending upon the patient's current state of sedation and concomitant sedative or analgesic use. Co-administration of Precedex with anesthetics, sedatives, hypnotics, and opioids is likely to lead to an enhancement of effects, and dosage reduction of Precedex or the concomitant anesthetic, sedative, hypnotic, or opioid may be required. Dosing of Precedex should be individualized and titrated to the desired level of sedation. Initiating Precedex therapy in patients already sedated with other sedatives or analgesic medications, such as propofol, midazolam, lorazepam, fentanyl, or morphine, is likely to lead to an enhancement of clinical effects and potential for side effects. Dosage reduction of these concomitant medications should be initiated when beginning a Precedex infusion. Precedex can be initiated with a loading dose of 1 microgram per kilogram over 10 minutes for both procedural sedation and ICU sedation. However, in patients already sedated with other agents, this loading infusion of Precedex may not be necessary. In long-term ICU sedation studies in which patients were switched from other IV sedatives, more than 90% of patients were not administered a Precedex loading dose.
In our practice, we don't use loading doses quite often because usually we're transitioning directly from an anesthetic into a light sedation with Precedex. For patients who are newly intubated, they for some reason need to be reintubated in my ICU, we will bolus them with the 1 mic and then start the infusion after that. But for the patients who are transitioning from a general anesthetic, we usually don't find it's necessary for those patients.
I tend to use loading dose where I'm using Precedex only. Having said that, most of the times I don't need to use a loading dose. Why? Because I'm bringing the patient from the OR to the ICU. It's the anesthetics. What I do is at the end of the case, I overlap my anesthetic with a low dose of Precedex. By the time I stop my anesthesia, there's a nice level of Precedex at the moment, and I can bring the patient to the ICU very comfortably without having to load him up. Also, when for the reason of the procedure, you need to give narcotics because it's a procedure that is painful. So you cannot neglect pain, even though reducing Precedex, you have to use some sort of narcotic or other type of pain management drug. So when the patient is very comfortable with a Versed or fentanyl on board, or even morphine, then I decide not to use a loading dose and just maintain optimal dose of Precedex throughout.
In the OR, if a Precedex loading dose is desired, consider the timing of administration to help ensure effective sedation.
My preference is to start the Precedex initial dose immediately when the patient arrives in the operating room. Literally, as the patient is moving from the gurney to the OR table, I hook up the Precedex tubing to the patient's IV and I start the initial infusion. Now, if you give the loading dose properly, the way the package insert recommends, 1 microgram per kilogram over 10 minutes, that patient will rapidly become sedated right in front of your eyes. Literally, by the time that loading dose is done infusing, that patient will be very nicely sedated. You then start the maintenance infusion and you watch the patient, and over the course of the next 5 to 10 minutes, the patient will be very nicely sedated. Deeply sedated, yet also arousable, interactive, able to follow commands, able to answer questions. So this is a sedative drug that works very quickly, and let me emphasize again, it does not depress the respiratory drive. So even though the patient is fully sedated, they're going to continue to breathe, they're going to continue to be stable, and they're going to continue to be able to interact with you. It's a wonderful way to induce sedation.
Prior to initiating maintenance dosing, consideration should be given to the existing level of sedation and condition of the patient. For procedural sedation, Precedex is initiated at 0.6 micrograms per kilogram per hour and titrated to achieve the desired clinical effect, with doses ranging from 0.2 to 1 microgram per kilogram per hour. For ICU sedation, Precedex is maintained at 0.2 to 0.7 micrograms per kilogram per hour. In pivotal clinical trials, most patients were started at maintenance dosages of 0.4 to 0.6 micrograms per kilogram per hour and titrated up or down to the desired level of sedation. As with other sedatives, dose reductions of concomitant sedative agents or opioid analgesics should be considered according to their respective dosing instructions and recommendations.
Let's talk quickly about adjusting the dose of Precedex during a procedure, during a course of sedation, during an operation. You must understand, because this is a drug that does not have a high infusion rate, when you adjust the dose, there's very small changes in the infusion rate. So for example, an 80 kilogram patient getting an infusion of 0.5 micrograms per kilogram per hour, that infusion rate is only 10 mLs per hour. Now if you go up to 0.7 micrograms per kilogram per hour, you're going to be increasing your infusion rate from 10 to 14 by 4 mLs per hour. Not very much. And you must understand, it's going to take you a while to get up to that new steady state level. So if you want to do that, here's what you do. Give another small initial dose, maybe 1/4 microgram per kilogram, over 10 minutes, then increase your maintenance rate. You'll rapidly get up to a new level in the bloodstream, and then you'll see the physiology that you want to see.
Following a loading infusion of 1 microgram per kilogram given over 10 minutes to healthy volunteers, the sedative effects of Precedex were observed in about 15 minutes. This is important to know so that pre-existing sedative agents or analgesics are not titrated downward too quickly before the sedative effects of Precedex have taken effect, or too slowly such that patients are over-sedated. Patients can be evaluated 15 to 25 minutes after initiating Precedex therapy or after each dosage adjustment to determine if adequate sedation, analgesia, and patient comfort have been maintained. A common question is how to transition patients currently sedated on other IV sedatives to Precedex. There are many potential ways to transition IV sedative agents. Each is unique to the patient and situation. This segment provides examples of the many methods available to give you an illustration of the common principles involved in transitioning to Precedex from other IV agents.
I get asked questions about how do you wean a patient off of one sedative and get Precedex on board? How do you adjust the dose of Precedex during a long course of sedation or during a surgical procedure? You must understand that you want to get Precedex up to a steady state level in the bloodstream. You want to get the drug on board as the other drugs are coming off board. Now, if all you do is start a Precedex infusion with no loading dose, you must understand it's going to take you many hours to get to a steady state level. So you're going to be dealing with other drugs being metabolized away, this drug increasing in concentration. It's a difficult situation. Let me suggest to you an easy way to handle that. Give a small, fractional initial dose of Precedex. Pick a dose, a quarter, a third, a half microgram per kilogram. Pick a loading dose, a small loading dose, give that loading dose, start your infusion. Wait half an hour. If in 30 minutes the patient is not sedated enough, give another small loading dose, repeat what you did, and see what happens then. Maybe you have to increase your infusion at the same time. My point is you're going to get up to some kind of level in the bloodstream as those other drugs come off. Okay? If the patient is deeply sedated in half an hour, just stay the course. Just stay where you are. Those other drugs will continue to be metabolized away, the Precedex will continue to increase, and you'll be just fine.
A common question is how to transition patients currently sedated on other agents to Precedex. Although there are many ways to transition propofol to Precedex, presented here is just one example illustrating how a transition from propofol to Precedex can be accomplished. One approach to weaning a patient off of propofol and onto Precedex is shown here. First, initiate the Precedex infusion in the patient already sedated with propofol at 0.4 micrograms per kilogram per hour. After 10 to 15 minutes, begin to titrate propofol down with orders not to increase. Check the patient's level of sedation every 15 to 25 minutes to assess the patient's depth of sedation. If severe agitation occurs, administer a bolus dose of a benzodiazepine at 1/2 to 1/3 the typical dose for resolution. Upon resolution of patient agitation, continue decreasing the propofol infusion. Do not increase the propofol dose in response to the presence of severe agitation. When titrating Precedex, increase the dose of Precedex in 0.2 micrograms per kilogram per hour increments. Again, assess the depth of sedation 15 to 25 minutes after increasing Precedex and prior to decreasing the propofol infusion. Continue to titrate down propofol until the infusion is stopped and the transition to Precedex is complete, assessing the patient every 15 to 25 minutes after each increase in Precedex. Simultaneously decrease the propofol infusion throughout the process. Address any episodes of agitation with bolus doses of benzodiazepines at 1/2 to 1/3 the typical dose. This is one approach for those clinical situations in which weaning from propofol to Precedex may be warranted. Once clinicians gain a level of comfort and experience using Precedex, other transition protocols can be considered. In Phase 3 pivotal trials of Precedex, mean total dosages of rescue sedatives and/or morphine to achieve a Ramsay sedation score of at least 3 and adequate analgesia are shown. As you can see, a significant reduction in rescue dosages of propofol, midazolam, and morphine can be achieved when co-administered with Precedex.
For patients who are on Precedex and you're thinking, well, how am I going to dose their narcotics? You can expect to use somewhat less narcotics than you normally would. Every patient's different, every situation is different, every operation has different analgesic needs. I usually would say you can start out with about 20% less than what you would normally start with. And if you need more, well, obviously you can give more. There's always an anesthesia, there's dictum, you can never take it out, you can always give more. But generally I would start with about 20% less than you would normally think of and dose up from there.
Precedex appears to reduce the opioid requirements typically about in half, somewhere between 25 and 50% reduction in the amount of opioids I typically give patients. Even in PACU, once the infusion's been stopped and the patients are awake, they appear to require less narcotics, or less opioids, if you will, for supplementation.
For non-intubated procedural sedation, the most common adverse effects with Precedex, defined as an incidence greater than 2%, are hypotension, bradycardia, and dry mouth. For intensive care unit sedation, the most common adverse effects with Precedex, defined as an incidence greater than or equal to 5%, are hypotension, bradycardia, systolic hypertension, and tachycardia. Moderate decreases in blood pressure and heart rate should be expected when initiating Precedex therapy. In Phase 3 clinical trials in SICU patients, Precedex-treated patients experienced an average decrease in heart rate of up to 7% versus placebo-controlled patients. Additionally, Precedex-treated patients experienced an average decline in systolic and diastolic blood pressures of up to 10% to 11%. Reports of hypotension and bradycardia have been associated with Precedex infusion. Should medical intervention be required, treatment may include decreasing or stopping the Precedex infusion, increasing the rate of IV fluid administration, or elevating the lower extremities. Pressor agents can also be administered if considered appropriate. In clinical trials of SICU patients, atropine or glycopyrrolate were effective in the treatment of most episodes of Precedex-induced bradycardia. However, in some patients with significant cardiovascular dysfunction, more advanced resuscitative measures were required. In 2 pivotal Phase 3 clinical trials of non-intubated patients receiving sedation for a variety of surgical and other procedures, the percent of patients meeting the study protocol definitions of hypotension, a systolic blood pressure less than 80 millimeters of mercury, or a diastolic blood pressure less than 50 millimeters of mercury, or a greater than 30% decrease from pre-study drug infusion values, was 54% of 318 patients. 65% of patients experiencing hypotension resolved without intervention. Of those patients that required intervention, the frequency of patients receiving various interventions for hypotension are shown. When intervention was required, the most common used were administration of ephedrine or phenylephrine, IV fluid administration, and Precedex dosage reduction. Similarly, the percent of patients meeting the study protocol definitions of bradycardia, heart rate less than 40 beats per minute, or a greater than 30% decrease from pre-study drug infusion values, was 14% of 318 patients. 73% of patients that met the protocol definitions of bradycardia resolved without intervention. As you can see, most patients did not require any form of medical intervention to counteract a temporary episode of bradycardia. Of those patients that required intervention, the frequency of patients receiving various interventions for bradycardia are shown. Among those who did, the most common intervention was the administration of glycopyrrolate, ephedrine, or atropine.
Heart rate can drop with Precedex. That is a side effect of the drug, especially in the bolus situation when the drug is given rapidly in larger doses relative to an infusion. So 1 mic per kilo over 10 to 15 minutes is a loading dose. You have 2 options. You can give less of a loading dose or you can give it more slowly if you feel that that's too quick. If you give a loading dose too quickly, you'll see a greater instance of hypotension and bradycardia. It's not common, I would say. Well, I mean, it occurs, but it's not overly common or usually overly bothersome. And we've given Precedex to people on beta blockers and not had a problem with reduction of heart rate.
I have not seen tachycardia and bradycardia a lot. I've seen it. I've seen though patients that go into AV block and patients that actually go from a first degree to a second degree. I would say probably I've seen it happen in 4 or 5 times in 4 or 5 years. What I do is I stop the drug. I stop the drug and treat the bradycardia. The majority of times in response to atropine. I think where Precedex is desirable is obviously on patients that are stable hemodynamically. I wouldn't start Precedex on somebody that's hypotensive and unstable.
I get questions all the time about the side effects of the drug. And there are 2 big concerns: hypotension, bradycardia. Let's address these concerns. Precedex is a blood pressure lowering medication. It's similar to clonidine in structure. Clonidine was introduced as an antihypertensive. You would expect a medicine like Precedex to lower blood pressure, and it does. It does so safely, it does so reliably, it does so predictably. The patient's blood pressure will go down. It is eminently treatable if it is too low for your comfort. It is very easy to treat the drop in blood pressure associated with Precedex. I give a little bit of ephedrine, 2.5 milligrams, 5 milligrams, and the patient's blood pressure responds dramatically and instantly. In fact, there's almost an exaggerated response to a dose of medicine that I would give in any patient. If you as a clinician are comfortable with a patient undergoing a spinal anesthetic or an epidural anesthetic or epidural anesthesia or analgesia for postoperative pain, then you ought to be comfortable with Precedex. In fact, the sympathetic blunting you achieve with Precedex is far easier to treat than sympathetic blockade you achieve with a spinal anesthetic or an epidural anesthetic. Those can be a little bit more refractory to recovery medications. Precedex will reliably lower heart rate in the majority of patients. Not dangerously, it'll lower it down to a very nice, safe level.
Caution should be exercised when administering Precedex to patients with advanced heart block and/or severe ventricular dysfunction, in ejection fraction less than 40%. Because Precedex decreases sympathetic nervous system activity, hypotension and/or bradycardia may be expected to be more pronounced in patients with hypovolemia, diabetes, chronic hypertension, and in the elderly. Clinically significant episodes of bradycardia and sinus arrest have been reported with Precedex administration in young, healthy volunteers with high vagal tone, or with different routes of administration, including rapid intravenous or bolus administration. Clinicians should be prepared to intervene with anticholinergic agents to modify vagal tone. In clinical trials, atropine, glycopyrrolate, or ephedrine were effective in the treatment of most episodes of Precedex-induced bradycardia. Transient hypertension has been observed primarily during the administration of the Precedex loading dose. Treatment has generally not been necessary, although a reduction in the loading dose infusion rate may be desirable. Precedex requires a continuous IV infusion. Due to its pharmacodynamic properties, the time to onset of sedative effects is generally longer than with other IV agents. Because of this, Precedex may not be desirable in situations requiring immediate rescue due to sudden onset agitation or acute sedative patient need. Following a loading infusion of 1 microgram per kilogram given over 10 minutes, the sedative effects with Precedex were observed after 15 minutes. Other IV sedatives may be more desirable to quickly achieve or reestablish the desired levels of sedation. If other sedatives or opioid analgesics are given in conjunction with Precedex, lower doses should be considered due to the pharmacodynamic properties of Precedex in combination with these concomitant agents.
The other thing that I want to comment on, and this is critically important, and I think it's a consequence of because of inappropriate use or selection, and that is the use of the drug as rescue therapy. Runaway rampant hypertension, runaway rampant tachycardia, a very combative, agitated patient who best might be immediately managed by other things. The drug's true value is, as I say, is in its prevention or the proactive amelioration of these acute or sustained increases in heart rate and blood pressure. And as I say, even though it's been described anecdotally in some clinical case reports for tachycardia and hypertension refractory to other conventional therapy, I think consistently one of the other lessons we've learned about the drug, as I say, in terms of rescue therapy, acute hemodynamic control, acute combative or sedative patient needs or states, perhaps other drugs might be more desirable. And well, the Precedex might be added or layered into some other drugs. As I say, the expectation for acute hemodynamic control and some of these other acute sedative and analgesic needs might be, instead of rescue therapy, thought of as I say, more of a component of the upfront administration and more of the proactive process.
The drug does not onset instantaneously as, say, Versed or propofol, and requires some time for the infusion to take its effect. So I think if sedation is required instantaneously, or there's a bolus situation where there's a variability of stimulation, where you're expecting a lot of pain, then no pain, then a lot of pain, Precedex may not be desirable in those situations because there's really not a bolus situation. You can bolus the drug, but it takes time to reach brain equilibrium. And again, as I said, propofol or Versed might be faster in those situations. And that would probably be one of the restrictions, is the time of onset for the drug.
I don't want to be dealing with hypovolemia and a sympathetic block. I would not use Precedex in a pregnant patient today. I'd be reluctant to use Precedex in a patient with high vagal tone, specifically a patient with an advanced heart block or a patient with a known history of vagally induced syncopal episodes, this kind of thing. I did once use Precedex in a patient like this, and the operation went just fine. But I would counsel people, I would be reluctant, you need to be cautious about using this drug in a patient with high vagal tone. Why? Because this drug is anti-sympathetic. It can blunt sympathetic input to the heart and cause a dramatically lower heart rate in those kinds of patients.
A higher incidence of bradycardia and hypotension was observed following administration of Precedex in patients over 65 years of age, and dose reduction may be considered in patients over 65. Precedex pharmacokinetics, Cmax, Tmax, area under the curve, clearance, distribution, elimination half-life, and steady-state volume distribution were not significantly different in subjects with severe renal impairment. Creatinine clearance less than 30 milliliters per minute versus healthy subjects. However, the pharmacokinetics of the metabolites of dexmedetomidine have not been evaluated in patients with impaired renal function. Since the majority of metabolites are excreted in the urine, it is possible that the metabolites may accumulate upon longer-term infusions in patients with impaired renal function. In subjects with varying degrees of hepatic impairment, Child-Pugh class A, B, or C, clearance rates for Precedex were lower than for healthy subjects. Precedex clearance decreases with severity of hepatic impairment. Dose reductions should be considered in patients with impaired hepatic